Welcome to my YouTube channel. Today we are going to talk about WHO 2022 updates on acute myeloid leukemia. Acute myeloid leukemia represents a heterogeneous group of genetically distinct disorders. If you can recall the previous WHO classification of AML and related neoplasms, you have 6 entities: AML with recurrent genetic abnormalities, AML with myelodysplasia related changes, therapy related myeloid neoplasms, AML NOS, myeloid sarcoma, and myeloid proliferations related to Down syndrome. So in the recent WHO, AML with BCOR ABL1 has been categorized as a separate entity. Previously, it was a provisional category in the WHO 2016. There are some modifications in AML with myelodysplasia related changes, and they have eliminated AML with mutated RUNX1, therapy related myeloid neoplasms, AML NOS. We have two broad categories under WHO 2022: acute myeloid leukemia defined by differentiation and AML with defining genetic abnormalities. Under WHO 2022 AML with defining genetic abnormalities, we have three new categories: AML with KMT2A rearrangement, MECOM rearrangement, NUP98 rearrangement. Along with that, we have AML MR, that is myelodysplasia related, and AML with other defined genetic alterations. And the most important thing is the blast cutoff. For all these entities, you require only more than or equal to 10% blast cutoff for the diagnosis of these AML with defining genetic abnormalities, except for BCOR ABL1 and AML with SEPA mutation. AML defined by differentiation, as the name suggests, the morphologically defined categories are assigned in this group. So in this WHO, these are the things which have been eliminated or modified. Like AML NOS category, there is elimination of 20% blast cutoff, which is reduced to 10% for AML defined by genetic abnormalities. There is no therapy related myeloid neoplasms and mutated RUNX1 in this classification. There are certain modifications in AML with myelodysplasia related changes. New entities in this WHO are AML with KMT2A, MECOM and NUP98 rearrangements, and AML with other defined genetic alterations. As I said, there is a reduced cutoff for AML with defining genetic abnormalities, except for AML with BCOR ABL1 fusion. In order to avoid confusion between CML BC and AML with BCOR ABL1, they have made this exception for the blast percentage. And AML with SEPA mutation also should have 20% blast requirement according to WHO, but ICC classification accepts 10% blast cutoff for AML with SEPA mutation. AML with SEPA mutation includes both biallelic SEPA mutations as well as single mutated SEPAs at basic leucine zipper region, that is single mutated B-zip SEPA. AML with other defined genetic alterations is a new category which is meant for new and emerging entities. In the previous WHO, we had AML with KMT2A MLLT3 as a separate category, but now they have introduced AML with KMT2A rearrangement as a new term which replaces AML with KMT2A MLLT3, because more than 80 KMT2A fusion partners have been described, with MLL-T3, AFDN, ELL, and MLL-T10 are the most commoner ones. Children with KMT2A rearrangement usually show megakaryoblast differentiation and morphology with the low blast count, whereas adults with KMT2A rearrangement have monocytic differentiation with high blast counts. AML with mutated RUNX1 has been eliminated from the recent WHO classification due to lack of specificity to define it as a standalone AML category. The previous diagnostic category, AML with MRC, is now called AML myelodysplasia related, AML-MR. These three are the important changes which are made in AML-MRC diagnosis. First thing is removal of morphology alone as a diagnostic premise to make a diagnosis of AML-MR. And they have updated defining cytogenetic criteria for the diagnosis of AML-MR. And they have also introduced a mutation-based definition based on the set of 8 genes, which includes SRSF2, SF3B1, U2AF1, ZRSR2, ASXL1, EZH2, BCOR, STAC2, which are usually seen in more than 95% of the cases arising from post-MDS or MDS-MPN. But now, if they have any of these genes, we can categorize the case as AML-MR. The previous entity AML with MRC is now has two separate categories: AML with myelodysplasia related cytogenetic abnormalities, AML with myelodysplasia related gene mutations. Let us see what are all the cytogenetic and molecular abnormalities defining acute myeloid leukemia, myelodysplasia related. AML-MR defining cytogenetic abnormalities include complex karyotype, that is more than or equal to 3 abnormalities on cytogenetics, 5q deletion or loss of 5q due to unbalanced translocation, monosomy 7, 7q deletion or loss of 7q due to unbalanced translocation, 11q deletion, 12p deletion or loss of 12p due to unbalanced translocation, monosomy 13 or 13q deletion, 17p deletion or loss of 17p, isochromosome 17q, etc. So you can simply remember the chromosome numbers at least 5, 7, 11, 12, 13 and 17p. So cytogenetic abnormalities involving any of these chromosomes is important for the diagnosis of AML myelodysplasia related cytogenetic abnormalities. These are the defining somatic mutations for the classification of AML MR related gene mutations, which includes ASXL1, BCOR, EZH2, SF3B1, SRSF2, STAC2, U2F1, ZRSR2. So WHO includes a set of 8 genes for the diagnosis of AML MR related gene mutations, whereas International Consensus Classification and ELN recommends additional mutation of RUNX1. So this schematic representation shows all the 9 genes which are required for the diagnosis of AML MR related gene mutations. If you can notice, BCOR, ASXL1, EZH2, these are the epigenetic regulators. RUNX1 is a transcription factor. STAC2 is a cohesin complex. And U2F1, SRSF2, ZRSR2, SF3B1, these are the splicing factors. So you can remember 4 group of genes which are required for the classification of AML MR related gene mutations. 3 epigenetic regulators, 1 transcription factor, 1 cohesin complex gene and splicing factor genes. Thank you.